The following episode is brought to you by the American Urological Association. This episode comes from the AUA Leadership in Business podcast. Whether you're starting your career or aiming to achieve professional growth, you can make the AUA Leadership in Business one of your go-to podcasts. If you enjoy the following content, please subscribe to the AUA Leadership in Business podcast via your favorite podcast app.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for today's dynamic professional landscape. I'm Dr. Jennifer Miles-Thomas. In today's episode, we will discuss urology practice management, overcoming operational challenges. Joining me today for this discussion is Dr. Brad Lerner. He is currently the president of Chesapeake Urology Associates. In addition, he is the United Urology Group ASC Medical Director and the Urology Service Line Medical Director for the United Surgical Partners International. Welcome, Dr. Lerner.
Well, thank you, Jennifer, for facilitating the podcast, and also thank you to the AUA for asking me to participate.
Well, thank you very much for participating. Well, let's start with the number one issue that every practice is dealing with right now, staffing. Can you describe your current challenges and what are some possible solutions that we are all experiencing?
No, great question. Obviously, very challenging area, I believe, for all of us. I think recruitment is the number one situation where, do we have the right pool of candidates? Where do we find them? We know during COVID, there were closure of a lot of training programs, such as medical assistant schools, some nursing assistant programs, things like that. So the pool of candidates is much less than it used to be. We also know that, there's an increased demand for salary and benefits, personal time off. We're now dealing with a scenario where people want to work virtually versus working live, where everyone used to work live. And so, there's a lot of changes in expectations as compared to, the prior workforce.
Kind of going to that a little bit more. So do you feel that post-COVID, it's a cultural change just overall in the workforce? Or do you think it's particularly present in medicine? I mean, we are very used to in-person care for a certain point. A lot of us have shifted to telemedicine. But do you think there's just a massive cultural change that we're going to have to really adapt to?
No, great question. As far as direct patient care, I don't think there's been a significant change. I think more when we look at supportive services, like on the operational side, administrative side, it's more virtual and less in person. But obviously, for direct patient care, while some services have changed to sort of a virtual type scenario, such as telehealth, by far the majority remains to be sort of in person and in-house as far as the staffing.
So we see out in the news that a lot of the larger companies are bringing people back in person. And for the support staff, admin side, billing side, things like that, there's a lot that can be done offsite. Do you think just us in medicine are a little bit slower for that uptake? Or do you think maybe we don't have the tools and the supervision set up in order to make sure that it's as efficient as it could be?
No, I think, in medicine, we tend to be traditionalists, right? As far while technology changes how we provide care to patients, we tend to be fairly traditional. But I think we also know that there are plenty of supportive administrative roles that can be done virtually. I think a big challenge is, well, how do you monitor productivity? Correct? I think it was a lot easier when you had people in house and you were able to directly supervise people and you got together in a room for a meeting and you walked out and, everyone was on the same page as far as deliverables. I think it's very challenging right now to be, in a virtual meeting with numerous people and making sure that people are paying attention, right? People have their video off, their audio off. And I think sometimes people are afraid to speak up or talk over each other, things like that. So it just becomes more challenging. But again, going back to what we do as physicians and providing urologic care, direct patient care, I don't believe that things have really changed dramatically.
That makes sense. Also, I mean, as physicians, we're used to not receiving accolades, right? Our emotional benefit of doing a great job and getting a thank you is enough. But it's different for staff. Can you talk about some of the things that you've seen that kind of help support staff and help them and recognize the value?
No, great question. So besides recruitment, I think, a lot of people focus on recruitment, but the bigger part of that is retention, right? So we can recruit all we want and we can hire all these staff members, but if we can't retain them and you're having this high turnover rate, it's makes it very difficult for your practice to be sustainable and for there not to be interruptions in patient care or supportive, operational roles. So, I think looking at how can you onboard people, how can you mentor them, providing opportunities for ongoing education, uh, provide opportunities for professional development, career advancement. And we have some people, I know some people in organizations where they started as a medical assistant and then they've moved up as far as furthering their development education into a high level administrative role. Like you said, great point. Recognizing achievement and value. I think that sometimes physicians take that for granted, saying, oh, well, they're doing what they're supposed to do. Well, everybody wants to come to work and be treated with dignity and respect, and they want to be valued. And I think it's really important. And it's not just valuing them monetarily. It's just they want to feel like, yeah, they're really playing a critical role in our ability to provide care to patients. So I think, recognize achievement and value. I know there are some practices where they put programs in place where you're actually able to recognize people's performance and you submit something to HR and they generate a certain level number of points and they're able to basically cash that in for gift cards or bonuses or things like that. So, I mean, there are ways to, again, show that you're recognizing what your staff is bringing to the table to allowing you to optimize the care of your patients. And I think it'll increase the ability to retain these staff.
Yeah, I can agree with you completely. And I think one of the hardest things about leadership is learning to let go. I would say that in the retention, so recruitment and retention of those superstars that we all know, yes, giving them opportunities to move up, to educate them, to level up, like the medical assistant you just mentioned. But then we know that we're going to actually lose them, which is an issue that we have to think about no longer just as individual physicians, but we have to think about what's best for the person as they move up this leadership chain. And sometimes that's challenging, but I think that's the best way to keep the really good people.
No, you're right. And I think that the flip side of that is recognizing when we have a poor performer. And sometimes we tend to say, well, a poor staff member is better than no staff member. And sometimes that can be extremely divisive and interrupt your workflow because there's other staff that are actually performing well or above what they should be. And when they see someone who's underperforming and there's not any change there, that can create some challenges as well.
I completely agree. Well, one of the things that I think is also very challenging once you are in a leadership position is to talk about revenue cycle management. It's something that we're not trained on at all in a residency or fellowship. And you kind of get out into the real world and you understand that there's codes, there's claims, you don't get paid immediately. Can you kind of talk through that and what we should know?
Yeah, so I think in general there's four sort of stages of what's called revenue cycle management, and I'll kind of elaborate them. But the first one is demographics and eligibility. The second one is claims creation and scrubbing. The third one is claims submission, and the fourth one is claims follow up and denial management. So if you look at the first one, demographics and eligibility, these are where the most common errors are, right? We get the patient's name incorrectly spelled. We don't get the proper insurance information. And so it makes it very challenging to find out, are they actually eligible for the services? Are we going to actually receive payment for the services? And also there's the pre-authorization process too, which we all get frustrated by, where, the rules always seem to be changing depending on which payer you're dealing with. We're focused on providing the highest level of safe, compassionate care to our patients. And it gets very frustrating when we want to proceed with a certain type of therapy that we feel is absolutely indicated. And then there's a roadblock that's put up. But again, this is where the information has to be entered correctly, by the staff, has to be checked, because that sort of sets you up for success for all the other steps. The next part is claims creation and scrubbing, and that's where sort of medical coding is transformed in the billing. And you're right. I mean, when you come out of residency and fellowship, you haven't had a whole lot of education in how to code properly. And actually, I look at it as making sure that you're compensated for the work that you do, right? And that's the important thing, making sure you have, all the supportive documentation for what you're actually coding for. So I think, listen, there's a big opportunity to educate providers on proper coding. I know the AUA has a lot of initiatives related to that, helping, physicians and APPs understand, global periods, what's post-op versus established, a new patient versus a consult, bundling versus unbundling, use of modifiers. Important thing is making sure that the documentation needs to support the coding appropriately. And then it sort of gets a little complex now, because payers have different guidelines, right? This payer will say, okay, for you to do a certain type of minimally invasive BPH procedure, these are our guidelines, whereas another payer is going to have different guidelines. And so, again, we're trying to do what's best for the patient, not always aware of what goes on with these varying guidelines. So we take care of patients, whether it's for medical therapy, whether it's for, surgical procedures, things like that. And so, obviously, if we're able to do the proper demographics and eligibility, the claims are being submitted, the claims are being created, we're making sure the proper coding is being done. The next is the claim submission. And again, if they're submitting the claims to the payers correctly, that saves time, right? You're going to get paid more in a timely fashion, and there's not going to be this back and forth where there's going to be denial of payment. And that gets very challenging, right? We know that there's some very effective medications that are very costly that have very low margins, right? And so we're trying to provide patients with this high level of care. And then you find out, well, you gave this patient medicine A or B, and now the insurance company isn't going to pay for it, whereas maybe the practice ended up bearing the cost of that. Same with some devices too. There's new technologies that come out, and we're going to talk about technologies, I think, a little bit later, but some of them are very costly, right? And so if we don't have everything in place, we may be providing care that at a significant cost that we may not be compensated for. Again, we want to make sure that also physicians, that there's timely completion of their charts, right? Whether it's electronic medical records, real time in the office, whether it's hospital-based care, because some of the payers do have a time limit when you're able to submit a claim. And we also know that, if there's errors, it results in additional work for our billing staff and obviously delayed payment. And then the last part of this is the claims follow-up and denial management, where, if you really want to achieve maximum revenue, for your practice, and receive proper payment for the work and effort that you do, you need to make sure you do have some type of, follow-up system. How do you deal with denials? And a lot of times it's due to interpretation. But there are a lot of times where the physicians actually don't put the proper documentation in the medical record, whether not having a voiding diary in place, not showing that, yes, they tried 4 medications and failed them all, but we forgot to document it. So I think it is important for the revenue cycle team to make sure that physicians understand what's needed on their part, because then they're just focused on providing the care to the patient and may not understand what really needs to be provided from a documentation standpoint.
Yeah, I think that's important. I think a lot of times it's been drilled in us just, take care of the patient, take care of the patient, which is the priority. But then there's more to that entire journey than just taking care of the patient. And yes, it's important that we give the patients or we allow the patients to get the optimal procedure, but it's also important to make sure that we're documenting why in our thought process so that it can go through the process. I just really feel that RCM or revenue cycle management is very much a process driven um, back end of any office. And unfortunately, we don't get much training. So thank you very much for going through that process so that at least people who haven't heard of it or hadn't gone through this kind of deep dive before can spend some more time learning about it and then helping their fellow physicians document and their teams submit these claims in a way that allow us to give the patient the correct care in a timely fashion and actually get reimbursed for it.
You're welcome.
Well, let's talk about another hot topic that's out there. It's just physician recruitment and retention. It is an interesting season in urology.
Yes, it is. I mean, we know the AUA has showed data that there's a growing shortage of urologists. We have more urologists retiring that are completing training. And so with an aging population, it creates more and more of a challenge just from the number of urologists that are out there practicing. And we know that there are many opportunities for people finishing training. Obviously there's, both of us are in private practice, but we know that there's non-clinical teaching, there's research, there's industry, there's consulting, then there's clinical practice. When you break down clinical practice, there's military, there's governmental like the VA, there's academic institutions, there's hospital-based employment, which is non-academic, there's managed care organizations, there's multi-specialty groups, there's solo private practice, there's small group private practice, there's large group private practice, and we also know that there's also affiliation with private equity as well. So there are a lot of choices for physicians, urologists that are finishing their residency and fellowship.
What do you think the greatest challenge is? Just the opportunities that are out there, or what should we think about when we're trying to recruit either lateral transfers or new graduates?
No, I think the challenge is that I think that the pool of candidates is listen, there's more jobs available than there are candidates finishing. So it's extremely challenging. There's a lot, again, there's competition from all these sources that we just spoke about, right? There's different private practices, there's managed care, there's hospitals, there's academics, there's all these other areas that candidates can move into. So it becomes very, very challenging. And then also I think we've seen sort of a paradigm shift over time with sort of this, what people tend to call work-life balance or sort of personal and professional goals. I think there was a time where there was more focus on professional goals, and likely now there is more of a shift towards personal goals. I'm not saying that's wrong, but the paradigm has certainly changed where, we're seeing a lot of candidates that are more interested in, alternative type of, work models, whether it's working part-time, things like that, issues, what prior generations felt was sort of a responsibility or an obligation, such as on-call coverage of hospitals. I think that there's now a newer generation of physicians that don't necessarily feel that way. And we know that we sort of have changed side of service care in a lot of areas where it used to be hospital-based and now a lot of shift into ambulatory surgery centers. So we don't have as great a presence in the hospital. So, again, it's an increasing challenge. I think that, the physicians that are coming out, listen, they're trying to decide between, personal, professional goals, work-life balance, geographic location. I think those are critical. I think if you look at surveys, a lot of people think, oh, it's about the compensation, the benefits. It's really not. I think that they know they're going to do well no matter where they go, wherever they end up. From an employment standpoint, it's these other sort of non-economic factors that really come into play.
I completely agree with you. Yeah, it's just similar to staffing our offices in the back end. It's a cultural change of expectations, and no longer are people just signing up to just be that solo practitioner or take care of the patient through the entire journey. I don't think we've moved to a culture where it's 5 p.m. and I'm off. We still have people who have that innate responsibility for their patients, but it is changing. And the balance, maybe before in the past, it was shifted more to professional development. Maybe it's shifting back to a balance of lifestyle, family life, and professional development. But I think it's up to us to try to figure out what will still work, what will still work in the business model, and what will work for individuals so that they can be truly fulfilled. Well, as we're talking about the difficulty in recruiting and the sheer number of patients that we have in urology while we are actively losing urologists, the thing that comes into question is patient access and experience, right? There's a wait in every locale right now. So, can you share some of your thoughts about ways to optimize this care and the patient experience?
Sure. Listen, I think that the most important thing that we as physicians and urologists need to understand is we should be providing every patient with a superior experience. That should be our focus. You know, some people say you need to be customer friendly. They're not really customers, but again, we want to provide people with a superior experience. And listen, there's sayings out there. The answer is yes. It doesn't matter what the question is. The patient's always right. Obviously, those are broad generalizations, but the principles are correct in that, again, we're trying to provide the highest level of safe, compassionate care to the patients, and we've got to make sure we're providing them with the superior experience, especially in the times of social media where, someone will put a bad review on you because you have outdated magazines in the waiting room, and it brings your Google rating down. I know or the parking wasn't as robust as they would have liked to see. It had nothing to do with your clinical care. There's dust in the waiting room, things like that. So it's somewhat frustrating for physicians sometimes where you sort of see these sort of comments that had nothing to do with the care you provided. It's all these sort of outside things. There's a lot of things go into providing these patients with such a great experience, and a lot of it comes back to what we talked about before is your staff, right? Because they're talking to staff on the phone, they're talking to staff at check-in, they're engaging with your medical assistant or your ultrasound tech or your physician assistant or things like that. So it's not just the physicians, and I think that you really want to develop a culture of excellence, and that's part of staff development is understanding what we're there for. We're there to provide care to the patients and want to make sure that they have the best possible experience. We also know that, the times have changed, right? That it's not just about direct facing with the patients as far as answering questions or concerns. There's email, there's patient portals, there's telehealth, things like that. So there's, other areas just other than the traditional sort of in-office practice.
It sounds like we need to take a little step back. A lot of times we think that the patients will just react to us and our relationship with the patients, which of course we know is usually a positive relationship. But we do need to think about the entire process, the entire patient experience, the entire journey, because that's what they're commenting on. And I love the fact that you said just a culture of excellence. And it kind of goes back to like recruiting the right people and making sure the good people who really want to do well and serve the patient and serve the community are the ones that we reward, and then therefore they will stay. It's hard. We're all working many hours putting in time after hours to think about these other aspects of business, the other aspects that actually contribute significantly, but we don't really see them. We just hear the complaints, but we don't see the process. So thank you for bringing that up, because I think that's helpful for a lot of people to kind of step back and look at the entire organization. So as urologists, we're known as some of the most innovative surgeons that are out there. We're nice, we're normal, and we're innovative. And so tell me about your process for evaluating these new technologies, right? Because we all hear about them when we go to the annual conference, when we go overseas, we hear about new things that are coming, but we just can't adopt everything. What is your process for evaluating?
No, great question. And you're right. It's been amazing when you look at what urology has achieved as far as, technology with endoscopy and robotics and minimally invasive surgery and, advancements in the care of cancer patients and things like that. And you're right. And we get inundated from industry. We know that our individual providers get numerous visits from members of industry talking about their products, saying, hey, why don't you start using medication A or B or device A or B or things like that. And sometimes we say, yeah, this sounds great, let's go ahead and do it, and they haven't done their due diligence. So what I recommend is an approach that's sort of a top bottom approach versus a bottom top approach. What I mean by that is things should be vetted, or the due diligence should be done by the leadership, or from whether it's physician leadership, corporate leadership. And then once you've completed your due diligence, then you move it down to the physicians or the APPs, versus the individual saying, okay, I want to try the newest, latest device here, and not understanding, first of all, it's not FDA approved. We're not going to get reimbursed for it because there's not an approved code. And we haven't figured out how to operationalize it. So the 4 steps I recommend going through whenever you're looking at some type of new service line, whether it's medication, device, things like that, is there's 4 steps. And it's regulatory, clinical, financial, and operational. I'll elaborate on this. So first is regulatory. We've got to make sure it's FDA approved. We know there's some things out there that are not FDA approved, or companies may say, hey, you can use this device or medication to treat this disease, even though that's not what is in their product information. So we need to understand the regulatory things. Now, first of all, it's got to pass the regulatory test. If it doesn't, we really shouldn't waste a lot of time on the other steps. The next is clinical. Does it make sense for our patients? Is it going to allow us to provide a higher level of care, safe care to our patients? Yes or no, right? If it's something that's going to provide inferior care or be unsafe, well, why would we want to look at it? So it's got to pass the regulatory test, the clinical test. Then you say, okay, does this make sense financially? Okay, is this something that actually will reimburse more than the cost, right? To say, okay, I'm going to implant a device that costs $20,000, yet I don't know if I'm going to get paid for it. Probably doesn't make a lot of sense. We want to make sure that we've done our due diligence and looked at the proper sort of coding. We know that there's been device or medications that have come out that haven't have a defined CPT code. They have unspecified codes. And so it's this gray area. Like sometimes the representatives from industry say, oh yeah, you're definitely going to get reimbursed for this. Yet we're the ones that are going to be responsible if we don't get reimbursed for it, not the industry members. So I think it's really important to do your due diligence. And it's okay to slow play this, right? You don't have to rush in and say, well, I need to be the first one to implant this device when you don't know if you're going to be paid. It's okay to wait. We know that we have alternatives to provide patient care. If something's going to be that earth-shattering that it's going to alter patient care, it's likely going to be fast-tracked as far as the benefit. So anyway, if you get through the regulatory side, the clinical side, and you do your financial, you do a business plan and say, okay, yes, this makes sense. Okay, we understand this is what our costs are. This is what we're going to be reimbursed from a professional fee standpoint. This is what we may be reimbursed from a facility fee standpoint. It makes sense to move forward this. Then you have to figure out how to operationalize it, right? Because you just can't say, okay, I'm going to now go do this new procedure in the hospital ASC, yet the staff has not been educated on it. They don't have the proper equipment or supplies for you to carry it off. And so there's be frustration from the physician standpoint. You may not get the outcomes that you want. So those are really the 4 steps: regulatory, clinical, financial, and operational. There are some groups that have like a new service line group where they put together some physicians, some operational people, finance, procurement, inventory management, things like that, to sort of vet new products and go through this process. So yeah, we're ready to go. Now let's operationalize it. There's also opportunities to do some product trials too on a preliminary basis, right? There may be some things where, well, we don't know if this makes sense clinically, right? And how would you know if it makes sense clinically if you haven't tried it? So there are some industry members that say, okay, we'll allow you to trial this product so you can see, and that it sort of helps you in your decision-making process.
Yes, that makes a lot of sense. I have seen quite a few different models where there are sometimes innovation committees that have different members that are looking different aspects. I think a lot of the hospital systems have an entire team that vets these products. But again, it's important for us to understand and know it. So when our partners come and present these new ideas and they haven't gone through the process, that we can be very we can be very, very straightforward about, hey, this is a business entity that you're trying to introduce, trying to bring in, and let's go through the process so everyone is educated. Because I think there's going to be a lot that comes in the near future that we will want to move into the patient care, and provide these services to our communities, but we have to understand the full circle and breadth of what we're asking. Is there anything else that we should consider? What about like contracts? I know a lot of us, especially if you're not in the executive leadership, don't ever deal with contracts, but there are many ways that we can kind of temper some of this initial burden. Can you give me some suggestions on what we should look at in the contracts?
Now, are you talking about as far as contracts? You're talking about as when we look at as it relates to vendors?
Exactly.
No, great point. So again, you're right. If you're not sort of in that arena, you may not be aware of different aspects of it. So there's the terms of an agreement, right? If you're going to agree to bring a certain product or device in, how long is the agreement going to be for? Is it 1 year, 2 years, 5 years? Is it automatically renewable? Can you terminate with or without cause, both parties? So you need to look at that. The pricing is important, right? Obviously, if you're looking at your business plan, you want to understand what the cost is going to be so you can look at what the reimbursement is going to be and see if it makes financial sense. There's different ways at looking at other aspects of the pricing as far as, are there any type of volume discounts or tier discounts, right? So if you are going to use a certain volume of a certain medication or device, or reach certain quantities, would there be potential discounts there? Will there be rebates? That's another way of looking at it. Other companies look at, say, hey, we know there's a lot of competition out there. We want to ensure that we have a certain percentage of market share. Okay, that you have, if you're going to use this product, we want 90% of the usage for you to achieve these certain pricing or discounts or rebates or things like that. So you have to understand, is that what your physician group wants, right? Do they want to be locked into using a certain product the majority of the time or not? And we know that physicians have certain preferences, but at the end of the day, there are certain products where it really doesn't matter. They're very comparable. There's not a significant advantage of one over the other. The other aspects people need to be aware of, especially for devices, there are service and preventive maintenance agreements, right? So it's, okay, yeah, we just bought the latest, greatest laser, but you know what? It's got to be serviced. There's got to be preventive maintenance. Who's going to cover that? How long is it going to be covered? Things like that. And then the critical thing, which we all encounter on a weekly basis, right, is the support from the company, right? The company representative, as far as providing the physicians, your supportive staff, and the patients with education, because that's critical and that needs to be ongoing.
I agree. I think onboarding And evaluating new technologies is important, but there's so many steps that are involved, a lot more than just, hey, this is the new product that I want to try. And thank you very much for kind of going through the steps, definitely the 4 steps that we all should think about, but also on the back end of maybe there are some tweaks we can do to contracts and things like that to make it actually work for our practices. Well, I want to say thank you so much, Dr. Lerner, for your time and expertise today.
Deborah, thank you so much for hosting this. Thank you to AUA again for inviting me, and I hope that all the listeners have found this content to be useful.